Good morning, everyone. Welcome to Pediatric Grand Rounds. And as several people have noted, I decided to suit up for when Carlo DiLorenzo comes to town. It's time to put on a suit. So Carlo DiLorenzo is the chief of pediatric in the division of pediatric gastroenterology, hepatology, and nutrition at Nationwide Children's Hospital and a clinical professor at The Ohio State University. He holds the Robert F. and Edgar T. Wolfe Foundation Endowed Chair in Pediatric Gastroenterology. The focus of his academic career has been the diagnosis and treatment of disorders of gut-brain interaction and motility disorders in the children of any age. He has published more than 400 peer-reviewed and invited manuscripts and co-authored the only 4 books on pediatric gastrointestinal motility. And maybe most importantly, his lineage of pediatric gastroenterologists focusing on motility and DGBIs have cemented his place really as the father of pediatric motility. He is a past president of the North American Society of Pediatric Gastroenterology, Hepatology, and Nutrition, has received the prestigious Schwackman Award for lifetime achievement and contributions to the field of pediatric gastroenterology. He has held leadership positions in the American Neurogastroenterology and Motility Society, the American Gastroenterological Association, the American Academy of Pediatrics, and the American Board of Pediatrics. He's responsible for first bringing motility to Pittsburgh, where he served as faculty from 1994 to 2004, until he left for Columbus. The reins of this program have now picked up by our own Viva Sud in 2019. Thanks for coming, Viva. Perhaps more important than all of his academic achievements has been his ability to relate the sometimes complex and nebulous concepts of neurogastroenterology to students and experts alike at the same level. He's a wonderful speaker, and I hope you enjoy his talk. Please welcome Carlo DiLorenzo as he presents the unavoidable academic of gut-brain interaction.
Thank you so much, Jeff. What a pleasure to be here again. I was telling the GI folks that I met for dinner last night. This is my first time back in 21 years. For some reason, even though I lived 3 hours away, I've never been back. And it's been tremendous just to drive around and go back, see the old neighborhoods where I spent so many great years when I was a younger faculty here. Those 10 years that I spent here made me fall in love with this city. I love Pittsburgh. I became, while I was here, both I and my family became, that's a problem if I cannot advance my slides. Is there any reason why the slides? I've done this before. I try both with this. I tried. All right. I was saying, and the timing got a little bit off, but I was saying that when I was here, I fell in love both with both myself and my family, with Pittsburgh in general, and became a huge Steelers, Penguins, and yes, even Pirates fan. And then going to Columbus, I have to disclose that regarding college, I kind of pivoted a little bit in becoming a Buckeye fan. So for those that are not big fans of the Ohio State University, it's going to be another year for you guys. But I enjoyed my time in Atlanta for the World Championship. But it was not just the city, of course, that made me miss this place so much. It's been also the people, right? So many great memories, so many great people here. I'm gonna just let this slide sit there for a little while just to soak it in. These are among the greatest physicians, smartest individual, best friends that I had throughout my career. And some of them are still here. Some of them have moved on, but those are the people that I miss tremendously. All right. Now that I got a little bit through memory lane, let's get to the meat of the presentation, the science. These are my disclosures. Well, actually, despite the fact that I consult with few companies, will not mention pretty much any medication. This is not a talk about medications or surgeries. So there is really no conflict of interest. I mentioned in the title the epidemic or disorders of gut-brain interaction, right? But is it an epidemic? What evidence do we have that disorders of gut-brain interactions are increasing in prevalence? First of all, GI symptoms are very common, right? If I just pick you guys, if I give a questionnaire to all of you, probably about 60% of you will have criteria to fulfill a disorder of gut-brain interaction. So these are very, very common condition, to the point that if you're symptoms-free, you should probably go see your physician and find out what's wrong with you, because that's not normal. But there are data that show that, at least in adults, irritable bowel, functional dyspepsia, in general, disorders of gut-brain interaction, functional abdominal pain are increasing in prevalence. There are at least two very recent studies, one from Norway. They show that the prevalence of irritable bowel increased between 2006 and 2018. And there's data from the United States as well. They show that that is increasing as well. And I don't know you guys, but for me, that I've been doing this for a while, there is no doubt that we are seeing more and more patients presenting with symptoms that are within the categories of disorders of gut-brain interaction, what used to be functional GI disorders. And not only there are more children who have this type of problems, but it seems to be particularly severe. I would say there is no time now that we do not have a patient on the inpatient service, 1, 2, 3 patients on the inpatient service that come in with symptoms severe enough to require hospitalization. And we did not used to see that severity or that frequency of disorders in the past. So why are they increasing? If you believe they're increasing, let's figure out why. First of all, we understand the pathophysiology of disorders of gut-brain interaction. Every time I hear a speaker talking about these disorders, I always hear, yeah, these are disorders of poorly understood etiology. No. We know very well why people develop irritable bowel. We know very well why people develop functional abdominal pain. And since we do, we know how to intervene, and we try to understand why they're increasing in prevalence. So why do they occur? The term says it. They are disorders. So there is a disordered gut-brain interaction. There is a heightened sensitivity, heightened motor responsivity of the GI tract, and there are luminal factor and cognitive factor that play a role. And together they generate the symptoms. The more severe the symptoms, the more likely that CNS factors play a role. So this disorder used to be called functional gastrointestinal disorders. Now they've been renamed DGBI, disorders of gut-brain interaction. One of the few times that changing the name actually, I think, serves a purpose. Now, when I tell somebody you have a disorder of gut-brain interaction, that opens the door to talk about the gut, which is what the family always wants to talk about, but also to talk about the brain, which is what I want to talk about usually when I meet them. So I think this is actually a great progress for the field. Not any easier acronym to remember, but certainly one that makes most sense, at least from the clinical point of view. And so let's talk about the gut luminal factor first. Are they increasing? Is there a reason why we are seeing more patients with irritable bowel and functional abdominal pain? Is that because there is something changing at the gut level? Unlikely, right? What has changed recently? Maybe COVID has played a role, right? Has played a role in many other things. We keep hearing about a lot of long-term consequences of COVID infection, and we have looked at that. We have looked, do children that went through the pandemic are more likely to have GI symptoms? And interestingly, initially, actually, this was a multinational study done in Israel, Italy, and the Netherlands and the United States. Initially, it seemed actually the kids were getting better. Maybe during the pandemic, maybe because they were staying home all the time. Maybe there was less stress of peer interactions in school. And actually, we found that children were actually benefiting from spending more time with the parents at home, and at least in the short term, that seems to be beneficial. But then we did another study a little bit longer term, once the pandemic was over and people were out again, and we found actually there was a worsening again, once they were put back in the environment where they were before the pandemic, especially in terms of emotional functioning, and especially in Italy, for some reason, they seem to get worsening of the symptoms. And then there was another study that was published just a couple of months ago, done in Chicago. That's not the easiest study to interpret, but basically in a lorry in Chicago, they took children who were getting tested for COVID, and some of them had COVID, some of them did not. But what they found is after 3 months, especially children that had a positive COVID test had more nausea-related DGBIs. So there is a signal that maybe that could have contributed to the increase in prevalence. And then there are data from adults. Adults always, of course, are ahead of the curve in doing large studies. And there have been many, many studies that have looked at adults that had experienced COVID. And much like many other post-infectious GI problems, they found that there was an increase in the prevalence of functional dyspepsia and IBS, two very common DGBI in the patients that had been affected by COVID. So 4% of patients after 6 months had functional dyspepsia, and 12% had irritable bowel while they did not have it before getting the infection. What about the brain factor? We talk about the GI factor a little bit. What about the brain factor? We have actually known for a while that the patients with more severe symptoms have a much more pronounced role of cognitive and psychological issues, right? You're not going to fix with a probiotic your patient who is having pain 24 hours a day, cannot tolerate any feeds. It's not going to respond to an anticholinergic. Those patients need something a little bit more than just a GI medication. And in fact, there is a new term that has been now endorsed by the Rome committee. Rome is what the committees that come up with the diagnostic criteria for DGBIs is called CAPS, centrally mediated abdominal pain syndrome. And that's a term that I use a lot as well. I think it's very helpful for me when I diagnose somebody with the CAPS, because that's a centrally mediated. So I'm going to be able to help you with, treatment that target the brain and not just the GI tract. We can target both, obviously, but at that point, if you have CAPS, once again, you're much more likely to respond to a different type of treatment that if you have like intermittent functional abdominal pain every now and then. And I don't have to teach you guys, we are in the middle of an anxiety epidemic, right? My hepatology colleagues for many years have talked nonstop about the obesity epidemic. And I want to see your obesity epidemic, and I raise you my anxiety epidemic, because this is much more likely to affect healthcare costs, quality of life, long-term outcome than any other, at least epidemic that I've seen in my lifetime. This is not going to go away, at least in the short term. We'll talk later about what we can try to do about it, but it is something that we better learn how to deal with it. If you are in GI, and if you are in medicine, maybe except unless you are a pathologist, you're probably going to have to deal with patients with disorders of gut-brain interaction. Or if you're not in GI, you're going to see your headaches, your back pain, your other somatoform disorders. Now, what evidence do we have? This is actually interesting and somewhat scary data. They looked at children presenting to the emergency room, emergency department, right? They looked at what type of complaints people had when coming to the emergency department. And in the blue line, the bottom line is any other reason to come to the ED. And the orange line is patients who come in with a suicidal ideation or suicidal attempt. You can see here the blue line is pretty parallel. Not much has changed. The orange line, you can see the worrisome increase in people presenting with a suicidal ideation or attempt. And there have been so many studies that have been published about the effect of COVID on children's mental health that there is a meta-analysis already based on 191 included studies with 1.4 million children. So pretty sizable size of this study. And basically what they found is that if you look at the pool prevalence of depressive symptoms, anxiety symptoms, sleep disturbances, it's about one third, maybe 40% of our youth struggle with anxiety, depression, or sleep problems. And then they found out, they tried to look at correlation with between life style factor and increase and mental health symptoms, and they found that geographic region, electronic use, and I'll come back to this, were part of the problem. And it keeps increasing over time. And it's very interesting because actually, this is a study that I did with John Campo, used to be here. I did this study when I was still in Pittsburgh. John Campo was the head of psychiatry, and then he moved actually to Columbus. And we looked at long-term outcome of children who were presented with what used to be called functional abdominal pain. And you can see here that what happens is sometimes the GI symptoms go away, but if you compare to a control group, they have much more problems with anxiety and phobic activity, obsessive compulsive disorder, and so on. So even 20, 25 years ago, 30 years ago, we knew that there is a huge correlation between the two. And sometimes we're good at fixing the GI symptoms. We were not as good, at least at that time, in dealing with some of the CNS problems. And why is that happening? It's the middle of a perfect storm. Why? Children has never been less active. They never slept less. They never had so much exposure to social media and iPhone. COVID didn't help. And parents have never been as catastrophizers and hyperprotective as they are now. And all those play a role in leading to the anxiety epidemic. Let me dissect a little bit some of these factors, because that's what I end up talking to the kids in clinic nowadays more than I talk about the stool pattern. Physical activity. WHO, which is a pretty important organization, right? It's not your local bridge club. Is there still a WHO, or has been outlawed in the last 2-3 weeks? But anyway, what they told us is that they recommended that children and youth between 5 and 17 should get at least 60 minutes of moderate to vigorous physical activity a day, right? More is better. And if you get this habit when you're younger, it continues later on in life, they found as well. How often does that happen? Less than 9% of children attending school fulfill WHO recommendation for physical activity. And once again, if you don't do it, if you're not active when you're young, you're not going to be active when you grow up. How does that compare to other countries? This is the standard test. Well, you guys probably know about this, right? The shuttle run test. You run 20 meters back and forth, and you can see how many times you can do it. And there's a standard test that is done pretty much all over the world. And you can see here, United States don't look too good. They are better than Latvia and Peru. Maybe that could be our next slogan. We're better than Latvia. But that actually doesn't compare well to almost any other country. Latvia actually just won an Academy Award. So they're not active, but they're good in movies. So I actually tell people often that one of the most under-prescribed medication is a 30 minutes walk outside every day. But what evidence do we have that actually helps the GBI? This is a study done in adult women with IBS, and just 30 minutes every other day on a treadmill. Not a lot. We can do 30 minutes. Our kids can do 30 minutes, maybe even every day on a treadmill, improve quality of life and decrease IBS symptoms. How does it work? A lot of ideas of how it works, but one of the things it does, it affects microbiota like everything else in life, right? Everything affects microbiota, and in fact, seems to decrease the type of bacteria that have been associated with increased risk of IBS, and actually affects intestinal permeability as well. So physical activity helps the brain, but helps the GI tract as well. And actually, this is such a big deal for me that I prescribe it. I still have I stole a prescription pad for the young people in the audience, the residents. We used to use those things to send patients home with medication prescription. So I still have it, and I still use it. I hide it from my colleagues, but I still add it to my AVS, to my discharge orders, and I write 30 minutes of aerobic activity forever. That's more powerful than just telling them. That's more powerful than just write it down in your list of discharge instructions. I'll keep doing it until I run out of paper. What about lack of sleep? That's the second most underprescribed medication, right? We're in the middle of the so-called great sleep recession. I don't know why in this study they use lines of a very similar color, but basically what it does, it shows the amount of sleep that people get, how many percentage of kids that get at least 7 hours of sleep by age on the left panel. And you can see here it goes down from 12 years of age to 18, and then a little bounce up at 19. And then in different 5-year intervals. And so kids sleep less and less the older they get through adolescence, and they are sleeping less and less every 5 years. There is a statistical difference there. And why is that important? Because lack of sleep is hyperalgesic. Just not sleeping for 24 hours causes your GI tract to become very sensitive. This is a study done by Ronnie Fass when he was in Arizona. And basically what he did, he asked volunteers not to sleep for one night. And then he put a little NG tube, nasopharyngeal tube, and he put some acid in their esophagus. And then he had a control group of people who slept. And just the lack of sleep made them have a lot more symptoms in response to acid. So the same amount of noxious element caused symptoms just because you didn't sleep. And then people have done similar studies by blowing balloons in the rectum of volunteers as well. So the lack of sleep make your GI tract more sensitive to almost any event. And in this study done again in Allori children, they looked at the correlation between lack of sleep, depression, and GI symptoms in children who presented with a variety of DGBI. And they actually found that the lack of sleep was independently associated both with GI symptoms and with depressive symptoms. So independently. So it made both things worse. So talk about sleep with your patient. And then the smartphone, right? You must have had grand rounds about the smartphone. I'm not an expert in social media, even though I'm unfortunately addicted to many of them. But these are data that show that smartphone ownership among kids 8 to 18, is going up a lot. There is no kids that is 14 older that does not have a smartphone. Actually, it's nice increase between 11 and 12, but this shows that between 215 and 221, there's been a significant increase, and I'm sure that if you had 24 data, would probably be in more increase as well. And this is a study done last year by the University of Michigan, and basically they looked at how often youth, adolescents interact with a smartphone. What they found is mean duration of use, 5.6 hours. That doesn't impress me. I beat this in most days. Median pickup per day, 51 times. Again, not particularly impressive to me. This is the part that I think is a little bit more worrisome. Median notification per day, 237. And 20% of children get more than 500 notifications a day. For those that are not big phone users, notification is you get usually a buzz, a ring or something, or every time there is something coming to you. So that's a lot. And mean use during school hours, about a little bit less than an hour. So this is, again, unlikely to change in the short term. And why is that important? Social media have a lot of good things and a lot of bad things. Displacement is one of the bad things, right? If you're on the phone, you're less likely to play with your friends, interact with the peers, to sleep, to pay attention in school and do other things. FOMO, this is true. People have actually done functional MRI brain studies looking at the fear of missing out, how much people are worried about social peers and comparison, and how that affects and contributes to mental health problems. We all know about cyberbullying and the body image problems. This is partially related to the excessive social media consumption. There are good things as well. I mean, I don't deny it. Improve connections. If you have a disease, you can make especially a rare disease. Sometimes you can make connection with other people that have the same problem. We have actually seen that become a problem as well. People become like, their disease warrior. They become their disease. And when you take it away, they fall apart. And there are so many patients come to see me that maybe they are given the diagnosis, the label of pseudo-obstruction or gastroparesis, which is now a diagnosis that is used fairly liberally. And when I tell them they don't have it, they are usually very unhappy rather than be excited because they have built a following, that they've become their disease. So that's another downside of the social media, right? And why is that important to somebody who deals with DGBI? This is a study done in the schools in Verona, Italy. Mauro Cinquetti looked at the variety of different possible risk factors. Not sure why he thought that pasta every day was one of the risk factors. But basically what he found is that being addicted to the smartphone double your risk of a DGBI. So there are data now in GI as well that correlate the severity and the prevalence of disorder of gut-brain interaction with the time people spend on the iPhone. And this is such a big deal, of course, as you know, the Surgeon General a year ago published an advisory about the effect of social media on the youth, on our youth mental health. We also know that IBS is a stress-sensitive condition. Any type of stress makes the patients with that have a predisposed GI tract to have symptoms. We have learned that in adults with IBS, there is often a very high prevalence of early life adverse events, what they call adverse childhood experiences. Anything from abuse to neglect to household dysfunction increases double, triple your risk of developing DGBI, sometimes many years later. And those are the ones that are more difficult to treat. If I talk to my adult colleagues, they will tell me that some of the most toughest patients they deal with are the ones who had a really rough childhood and were exposed to a variety of adverse childhood experiences. How does the stress work? By affecting your GI tract. This is a phenomenal study. By the way, just a secret, when a speaker tells you about a great study or a phenomenal study, usually it's just a study that confirms its narrative. Doesn't really mean necessarily it's a great study. Sometimes there are studies just as good on the opposite side, but this is a really great study. This study looked at, they measured cortisol level, salivary cortisol level, and they measured, they gave anxiety questionnaires, and they look at gut permeability in young people having their PhD thesis, the day they were going to present defend their PhD thesis. So just giving a presentation, a little bit like what I'm doing now, but maybe with a bigger stake there. And then they compare them to people receiving an electric shock on the skin. And then they had a control group, and then they had another group in which they gave them non-steroidal anti-inflammatory drugs. And you can see here, the giving a speech was just as bad in terms of cortisol production as getting a shock. But even more interestingly, when they look at permeability, giving a speech causes an increase in gut permeability similar to getting NSAIDs, which are well-known noxious medications for the GI tract. It was even worse than getting a physical shock, electrical shock, and certainly a lot higher than in control. So stress affects the GI tract function to the point of affecting the permeability. And finally, the role of the parents, right? We cannot, if you have, once again, been in GI clinic more than 2 weeks, you know that sometimes you have to deal with the parental anxiety more than the child symptoms. We have known that having one parent with an anxiety problem increase your risk of having what used to be called recurrent abdominal pain in children. Having 2 parents increases double the risk. If both parents are very anxious, the chances of your child or having a DGBI will be double. Not only that, but we've also learned that how the parents respond to the GI symptoms has a great influence in their ability to overcome the symptoms, to cope with the symptoms. You can see here this other study published 20 years ago, look at the severity of abdominal pain complaint and correlated that with what they call maternal reinforcement, the attention and the rewarding and the secondary gains the child was getting in response to the symptoms. So you can see here, once again, The more severe symptoms were associated with more what we call inappropriate parental behavior, reinforcement of the symptoms. And actually, I have an uncle in Italy who is a pediatrician. His name is Giuseppe Ferrari, and he has been one of those pediatricians in the front line for many, many years. He even organized a meeting in Italy. I remember he invited Basil Zitelli to go to Italy. But basically, he published a book, a bestseller in Italy, that says children grow well despite their parents. And that, I think, has a lot of wisdom there. If you read Italian, you're fluent in Italian, you can buy this on Amazon, and it's a really good book. So what can we do about it, right? I think I convinced you that the gut and the brain work with each other. I think we made a case for this being a serious problem that is unlikely to go away. First of all, let's talk about it. Representation matter. I found that since Simon Biles and The Rock and Michael Phelps and Demi Moore and Emma Stones have come out talking about the mental health problem, Naomi Osaka stopped playing tennis when she was #1 in the world because of mental health issues she was experiencing. This is a big deal. But people have heard about this. I find it a lot easier now to talk to families about the role of anxiety and stress and mental health issues on the somatic symptoms, much easier than it was even 5 years ago, certainly much easier than 20 years ago. They often welcome that you open the door to that because they are worried themselves sometimes that that's part of the child problem, that it's not just a bellyache, the real issue is something else. So having all these people come out and discussing their mental health has made a huge difference in my ability to relate to the families and talk about these issues. Avoid excessive testing. I'm terrified of incidental findings. Medications have side effects, but diagnoses have side effects. It's very hard to undo a diagnosis. Once you label somebody with something, you try to undo it, they're going to go see somebody else because they don't believe you. They believe the first one who told them that the problem was this specific little things that they found one time, right? It's been said it's more harmful to miss an anxiety and depressive disorder. They diagnose a little later celiac disease or H. pylori infection. Nothing happens if you diagnose somebody 3 months later with a celiac disease, but it's a big deal to miss an anxiety disorder. The child is not able to function because of that. So I'm going to give you an example. And once again, this happens all the time. You scope a child, you scope a child with a bellyache, and you find eosinophilic esophagitis, right? You take the biopsy, unfortunately, and that confirms that that's what you have. Does that really what's causing the child abdominal pain, a problem in your esophagus? People have looked at that. Another great study that confirms my narrative. This is one that in this study, Sandeep Gupta and colleagues took patients who had presented with that exactly scenario. They presented with abdominal pain, and they were found to have eosinophilic esophagitis. And then he compared to other patients with dysphagia and EOE, eosinophilic esophagitis. EOE gives dysphagia. And then he treated the eosinophilic esophagitis, and what he found is the patients with dysphagia, the dysphagia got better by treating the EOE. The patients with bellyache, 70% did not get better. You're treating an incidental finding. Now you're stuck having to swallow steroids. You're going to develop yeast esophagitis. You have to scope them again to see if that is going to away. And then maybe it didn't go away. Now you escalate your treatment. You're treating the wrong problem because you never try to address the real issue. So when you do tests, there is a downside to it. You try to provide reassurance to the family, but sometimes you find things that are really unrelated to the patient's symptoms. And in fact, this is a beautiful editorial that was written by Sam Nurko, one of my colleagues in Boston, and Neil Schechter, who is a psychologist. It's called Unintentional Symptom Intensification by Doctor. If you can take one thing away from this presentation, it's just 2 pages. Read this editorial that was published in Pediatrics a few years ago. Basically, what they say is that by doing all this testing, we are in danger of diagnosing rare entities, right? To accommodate, sometimes we stretch the symptoms. There are maybe diagnostic criteria, but You don't fulfill them completely, but you probably have it anyway. And now it's very hard to remove that EDS or that POTS diagnosis or the mast cells activation. And people have gone as far as saying, are we dealing with Munchausen by doctors? And I, unfortunately, because I see a lot of third, fourth, fifth opinions, as much as I try to give my colleagues a break, and I'm very gracious to everybody because I don't know what was happening at that time when they first encountered the patient. But sometimes I see that the easy way out is to tell them, somebody, you have gastritis, you have constipation, you have this, take some laxatives make the pain worse, and then you begin to escalate, and then you don't know anymore what's doing anything. It's very difficult to take away medications besides taking away diagnosis. So many times, the child is in my office, horrible symptoms, list of medication, 12 medications. And I say, are these medications helping you? Absolutely not. Nothing helps. Okay, let's stop all the medications. And it's a panic attack. They don't want to stop the medications because, you know, they are afraid that it's going to get even worse. So be suspicious of novel non-infectious disease. Once again, one of the beauty of getting old is that you've been through a lot. So I've seen epidemics. For a while, everybody used to have a mitochondrial disease. Everybody used to have gallbladder dyskinesia. Now I went to the gluten intolerance, and then a POTS and the early downloads, mast cells activation. Now we're in the middle of median arcuate ligament syndrome epidemics and alpha-gal epidemics. I mean, for some reason, these are not infectious problems, right? If COVID comes out, I understand you get new diseases, new symptoms. But these things, the anatomy has not changed. The inflammatory response has not changed. Those are things that often become popular and then disappear. But because of social media now, everybody seems to feel that they have that. You know, the GI tract is not a very smart organ. They only have 5 symptoms, right? They only have nausea, vomiting, abdominal pain, constipation, and diarrhea. So everything sounds the same. I tell patients there are 173 diseases, GI diseases. I make it up, 173, but it sounds like a good number. It seems like I know what I'm talking about. And I tell you, there are only 5 symptoms. So it's obvious that your child sounds exactly the same as this other one who was diagnosed with MALS, but your child does not have it, trust me. You need to learn how to deliver good news. People go through medical school and they receive training about how to deliver bad news, right? You probably had lessons or scenario in which you tell somebody that they have some bad disease. I bet nobody has ever had a lecture on how to deliver good news. And people, sometimes my colleagues or my fellows are terrible at it. They almost become apologetic. We did a scope. We didn't find anything. Well, we didn't find anything. We found fantastic physiology, fantastic anatomy. You have the best colon I've ever seen in the last 3 years. You know, this is fantastic news. Your child does not have Crohn's disease, does not have ulcerative colitis. We know exactly what your child has. Has irritable bowel, no more tests are needed. I've seen this before, and I'm one that worries about a lot of things. I'm not worried about your child. And I often bring up this other study that is actually a great study because it helps me making the child, the family feel good about my diagnosis. Actually, if you look at this study done in the UK, basically they found that having IBS protects you from death, at least in the short term. In the short term, maybe because patients are so vigilant about the symptoms, maybe because they go see the doctor all the time, but patients who they received the diagnosis of IBS had less risk of dying for the few years after the diagnosis. So I have good news. Your child has a condition that protects him from death. And then you try to treat the brain, right? You've done the best you can. You're not a psychologist, you're not a psychiatrist, but you are a physician. So I think you need to become comfortable making referrals or using some medication. In some way, our colleagues in pediatrics, our pediatricians are much more comfortable dealing with the anxiety and ADHD and a lot of mental health issues, much more than us subspecialty, which we can use tacrolimus, we can use infliximab, but God, it's citalopram or amitriptyline. I don't touch those drugs. It's a lot easier, a lot less dangerous drugs. The treatment never fails. Cognitive behavioral treatment, hypnotherapy. I don't think there's ever been a negative study in any condition in medicine that has shown that this intervention do not help. I only seen positive effect. You can see here like 10, 12, I don't know how many there are studies, well done, randomized studies comparing hypnotherapy to medical treatment in children with functional nausea, with functional abdominal pain, and so on. The challenge for you guys is to learn how to make the referral without giving the impression that this is all in their head. I usually tell them a very specific, I give the example of a headache, you know, that is another condition that often does not have a disease causing it, but is real. So you need to learn how to be comfortable in making the referral. Sometimes it helps, like in our case, we have a psychologist in our clinic, we go together or they go one after the other. So it's easier when you see them at the same time, rather than make a referral and waiting 3 months or 6 months to see the psychologist. But there are other ways to deal with this. For example, there are now digital therapeutics that can be used. There are 2 that are FDA approved, that you can prescribe them, you know, the Mahana and Regulora, those that teach self-hypnotherapy, they teach self-cognitive behavioral interventions. And there are 2 that are over the counter, Zemedy and Nerva. They are not free, but they are not incredibly expensive compared to even over the counter, you know, sometimes herbal remedies and so on that our families use. The problem is if you just tell them to use them and they go home, they never sign up. You need to make them do it in clinic with you. And have, you know, I'm going to have my nurse come in and help you, you know, sign up with some of these apps. And then you need to give them, this is a homework, right? This is like an athlete going through rehab. Your child has significant symptoms. They're not going to go away in one day, but these things have very strong evidence, scientific evidence, they work. And there are studies with each one of these showing that they help. They are not always the same. I tend to use more the Nerva one, but the other ones are just as good. What about psychotropic medications? Again, this is the only couple of slides they're going to use about medications. The 2 that I use the most, one is amitriptyline. People have used amitriptyline for migraine prevention, for cyclic vomiting prevention. So this is a long record of being used in the GI literature. This is a study done in India. It was a little bit of an odd study. It was placebo-controlled, but open label. So the physician knew which one was getting the placebo or not. But basically, look at the thing in yellow, 76% reduction in pain in the patient, children receiving amitriptyline compared to the only 15% in the placebo group. I tend to use it when it's more pain predominant symptoms, when patients usually have something else like nausea or a lot of anxiety. I actually tend to use more citalopram. This is another study. This is an SSRI, amitriptyline tricyclic. It's a TCA. This was a study done again by that I did together with John Campo once again here in Pittsburgh, and we looked at the use open label, not a great study, but open label, but fairly strong signal here. Percentage of patients responding on the left, and you can see that after 8-10 weeks of citalopram use, 80% of patients had improvement in abdominal pain, and that they improved somatic symptoms and anxiety as well. And I think I surprised many of my colleagues often when I say that I end up nowadays prescribing more citalopram than omeprazole. And I get more requests for refills for citalopram that I get for omeprazole. That tells me that it's working, because when they ask for the refill, means the family is finding a benefit from it. Other neuromodulation is around. I don't know how much you guys know about the percutaneous electrical nerve stimulation. This is a little bit of a conflict of interest for me. 2-3 years ago, I was in on the advisory board. I'm not anymore. But basically, this is a device that you put under your ear. It looks like a little bit like a hearing aid. You put it for 5 days, 4 consecutive weeks, Monday to Friday. You take it off on Friday. You take it again Monday to Friday. And this is the only device that has been FDA approved. The only intervention. There is no medication, nothing else has been FDA approved for use in children 11 and older with irritable bowel or functional abdominal pain. You can see the data on the right side showing an increase in improvement in pain compared to sham stimulation. And as I said, in 2019, this was FDA approved. I don't know if you guys use it here. You guys use it? Okay, you do. All right, so that's has been something actually family like it. I think they like this more sometimes more than a pill, or certainly has no downside except maybe the cosmetic appearance. And there are some recent data actually that show that you can look on the right, abdominal pain, nausea, functional disability, all seem to improve by using this device that stimulates afferent nerves to your amygdala and the rest of your brain stem. So there is something to it. To be completely transparent with you, I do not find it as successful in my practice as the literature reports, but I keep looking for the right patient and I keep trying to identify who is the most likely to benefit from this fairly non-invasive intervention. And finally, start treating the parents, right? We mentioned before how much parents play a role in either in the child wellness or in the child persistence of symptoms. They need to model appropriate response. They need to be taught what to do when the child complains of pain, right? They need to we need to reward healthy adaptive behavior and use distraction and avoid negativity. This was actually another study that I often bring up because this was an NIH-funded study by Rona Levy in Seattle. She randomized 200 children with abdominal pain to either having parents been taught how to respond to the pain or having parents not to be taught anything. It was a control group. So basically, she treated the children with pain by using what she called social learning, giving tools to the parents to respond to the child's symptoms. So not much for the child. The child was just having the regular treatment, so the two groups. And she found, of course, that the parents who were taught what to do when the child complained of pain did much better. The children did much better when there was that environment around them. So going to finish with some take-home messages, since I was asked to leave 10 minutes for questions. TGBIs will continue to increase, right? This is not way, you cannot escape it. We need to recognize and talk about the importance of stress, anxiety, and depression generating somatic symptoms. We need to learn. This is probably what our fellows need to learn more than they need to learn how to get into the TI as well, but they will learn that. They need to be taught how to deal with these families. And in our fellowship, it is mandatory to do a rotation with psychology. So I think they need to learn to see how these things are addressed. Lifestyle factors, as I said, I always ask how much sleep they get, how much smartphone use they have. And you're not going to stop. And you shouldn't stop completely smartphone use. There is a lot of benefit from it. They're going to be in withdrawal. There is evidence actually that the abrupt discontinuation of smartphone use is not good either. But come up with small, achievable goals. Maybe don't use it 1 hour before going to bed. Don't use it at the dinner table. Don't use it, just small, achievable, like you do with obesity. Small, achievable interventions that make you then feel better about yourself. And there are things that can be sometimes accepted by the patients as well. And then at the end of the day, I also feel that prevention and treatment require intervention at the level of training of medical providers. We need to be comfortable with these diseases. There is plenty of data that pediatric gastroenterologists enjoy dealing with pancreatitis and Crohn's disease a lot more than with functional nausea and irritable bowel. And that's not quite right. Societal recognition, still a bias, a little bit there, less than before, but there's still a bias towards acceptance, the importance of mental health problems. And I'm going to finish by showing what my barista, when I go to a place where I get my breakfast during the weekend, knows me so well that whenever he makes a cappuccino, she actually often makes a gut and a brain. It's really good about it. All right, I'm going to finish up. Happy to entertain any question you may have. Thank you so much for your attention.